Let us start discussion on the fracture shaft of the femur. We have chosen this case and this topic because of certain reasons. It is very common injury which is asked in the examination, either in OSCE, MEQ, or MCQ, or many times its complication with the malunion, non-union comes as a case of long case, and then externals and internals will ask you a lot of questions on it. So let us try to understand the concept of the fracture shaft of the femur. Let us see the magnitude of the problems. It is common injury in the major violent trauma. So as the speed of the vehicle is increasing, it is becoming commoner. Usually one femur fracture in 10,000 of the people. It is a fracture of the young people most of the time. 25 years to 65 years is the common age group that you find the fracture to be prevalent. Femur fracture, it leads to reduced activity for a much longer time, more than 100 days, and hospital stay is also prolonged close to 1 month, exactly 25 days statistically. And motor vehicle, natural disaster, sports and construction injury are the most frequent causes. Now let us see how it happens. Mechanism is always high energy trauma. It is associated with certain peculiar conditions. Say example, femoral neck fractures. 10% of the femoral neck fractures can occur along with the shaft of the femur, and 30% of the time it remains undiagnosed. There could be bilateral femoral fractures. In case of bilateral femoral fractures, the pulmonary complications are very high, and there is increased mortality as compared to the unilateral fractures. The some peculiarities of the anatomy of the femur must be understood, because it helps when you open the fracture or you put the intramedullary nailing device. You should know the peculiarities. One is it is the longest bone, but more importantly it has got very powerful muscles attached there, and every implant that you are putting must counteract the forces put by the muscles. It is curved anterolaterally, it is narrow at the isthmus and flayed at the ends. So when you put the intramedullary nail device, they will be as much bigger in diameter as the isthmus will allow, or else you have to widen the isthmus, and they are not snugly fitting at the ends of the femur, in both ends, superiorly and inferiorly. So remember, they will be not snugly fitting with the cortex, and it won't be a good fixation when there is a fracture in the ends of the bone. So this is anterolateral bowing, and you can see the narrowest part is at the isthmus. It is usually at the junction of upper third and lower two-third. Now see the one more peculiarity, the curvature is usually 120 centimeter. It is curved 120 centimeter, whereas our nails which we are going to put inside, they are straighter. Their radius of curvature is 150 to 300 centimeter. Remember some of the special features when you are putting intramedullary interlocking nail is you have to ream the medullary canal to have the larger diameter nail to be fitted in. So reaming will definitely destroy the endosteal blood supply, but the periosteal blood supply increases. But at the end of 8 to 12 weeks, the medullary blood supply is re-established. Theoretically, not reaming the intramedullary canal or medullary canal will have the better blood supply always. But at the end of the 12 weeks, whether you ream or don't ream, the blood supply remains the same. There is a classification based on the comminution. It is called Winquist and Hansen classification. So type 0 is there is no comminution. Type 1, it is insignificant butterfly fragment with transverse or short oblique fracture. Type 2, the butterfly fragment has become larger but is still less than 50% of the bone width. More than 50% of the bone width still remains with the parent bone. Type 3 is now the butterfly fragment has got more than the 50% of the cortical width along with it. And type 4 is segmental fracture or gross comminution. So you can see it is type 1 insignificant butterfly fragment. Here it is significant but still less than 50% of the width of the cortex it is containing. In the type 3, it has become larger and more than the 50% of the cortical width is with the butterfly fragment. And type 4 is segmental. AO classification is supposed to be the better, but it is complicated one. We are not going to discuss in details. This is also called Muller AO classification of the long bones. It is based on whether the fracture is simple, wedge, or complex. Now, forces fracturing the femur will cause different patterns of the fracture. Say, for example, indirect force, meaning twisting. Twisting forces in the femur will cause long spiral or oblique fractures. The direct force means it is extremely violent force. They will cause transverse fracture. It will be associated with the other injuries. There will be comminution and there will be more of the soft tissues injury along with the fracture bone. Whereas the trivial force will cause pathological fracture. Deforming forces, iliopsoas pulls the proximal fragment into flexion. Gluteal muscles pull the proximal fragment into abduction, and adductors pull distal fragments superiorly and medially, causing shortening and varus deformity. You can see it, gluteal muscles pulling the superior fragment or upper fragment into abduction. The iliopsoas pulling the upper fragment in flexion. Adductor muscle, they are pulling up the distal fragment, causing the shortening. And remember, these muscle forces must be overcome to reduce before you think of putting any implant. That implant should be strong enough. For descriptive purposes, what you should do is you have to divide the femur in three parts: upper third, middle third, lower third. And then you start your diagnosis, examination, or the findings. We'll come to that again. So, when the clinical features you are taking at the same times, there could be pain in the upper third, middle third, or lower third of the thigh. That has to be taken into account while taking the history. Where is the pain? Not thigh, it will be either upper third, middle third, or lower third. Swelling again, either in the upper third, middle third, or the lower third, that will give you an exact location of the fracture. Deformity, again the same way, upper third, middle third, or lower third. Shortening, you can see it. Loss of function. The patient may be in shock because there is 1 to 1.5 liters of the blood loss, and there could be compartment syndrome. And after the second day, when you have to look for the patient's complications, it could be fat embolism syndrome that has to be taken care of. When we start the examination, general examination comes first. We start with the vital signs and pallor. You have to look for the signs of hypovolemic shock. After second day or after 48 hours, you will start looking for the signs of fat embolism syndrome. There are three cardinal signs. One is the cerebral signs, another is the respiratory signs, and the third will be the signs of skin, particularly hemorrhages. The DVT or the pulmonary embolism, they are common after a week or so, usually peak at around 2 weeks. And in frail patients, weak patients, old patients, always look for the better stroke. They can come in a few days' time. When you start the local examination, you start with the inspection. The attitude has to be described. That swelling you will be describing, especially the swelling here is usually diffuse and circumferential. The deformity, when you are describing, deformity can be in different forms. Deformity is a translation. Is it translated? The distal fragment is to be taken care of in comparison to the proximal fragment. Is it translated anteriorly or posteriorly or medially or laterally? This is called translation. It could be bent. So bending is also a form of deformity. Rotation is a form of deformity. Shortening is a form of deformity. All has to be seen as a case of deformity. The skin, the bruises and ecchymosis in the recent cases, scar and sinuses will be looking for in the old cases. Muscle wasting, always in the late case, cannot be present in the short or cannot be present in fresh cases. And when you look for the limb length discrepancy, you have to look at the level of medial malleus. If one side of the medial malleus is up, it means that particular limb is shorter than the normal limb. And when you find that limb to be shortened, you have to do the segmental shortening on inspection itself. So you see the level of superior pole of the patella. If in a case the medial malleus, say for example on the right side, medial malleus is up, it means right limb is short. And when you see the superior pole of the patella, and that superior pole of the patella is also proximally placed, it means shortening is in the femoral segment. Remember, as a student, when you find shortening in the femoral segment, in the measurement, you have to draw a Bryant triangle to differentiate it from the supratrochanteric shortening. Now, for the signs or on palpation, the temperature is to be taken, usually raised. The tenderness will be on the fracture side, either middle third, upper third, or lower third. You will define the deformity, either it is the form of the angulation or shortening. You will be defining the swelling as you have seen in the inspection. And while you are taking the tenderness, don't forget to palpate for the diagnostic pathognomonic signs of fracture. They are fracture gap, irregular bony surface due to protruding edges, or this is called maybe step sign, abnormal mobility, and while it is moving over one another, you may feel the crepitus. They are the cardinal signs of fracture. The muscle wasting in late cases and limb length discrepancy as described in the inspection part. You will be putting your thumb over the bony points and then demonstrating it is short. Remember, confirmation of clinical diagnosis is most of the time with the abnormal mobility. Now, movements are always painfully restricted, not advisable to do it. Measurements, there are two types. One is the true and one is apparent. Apparent is easy. From GP sternum to the tip of medial malleus is the apparent measurement on both sides. Then true measurement, the prerequisites for the true measurement are: one, the pelvis must be square. It means both ASIS must be at the same level and both limbs should be in similar position. And then you put your measuring tape from the ASIS to the tip of medial malleus. Once you find it is short, then go for the segmental measurement. Segmental is The femoral length is from the ASIS to the medial joint line, and the tibial is from the medial joint line to the tip of medial malleus. And lastly, don't forget, look for the neurovascular examination. How will you be putting the diagnosis? You must tell it is traumatic or pathological. You must also add whether it is closed or open. And then you have to talk about site and the bone fracture, also the side of the bone fractured. So either in the upper third, middle third, lower third. Femur, right or left, has to be taken care of while you are describing. And type of the fracture, you have to tell whether it is complete or incomplete. Also, if at all you are getting some indication whether it is displaced or undisplaced, put it under the diagnosis. And then don't forget to tell neurovascular condition as well. What could be the associated injury? Because it is a high velocity injury, it could be associated with the several injuries from other parts of the body. Say, for example, abdominal injuries, head injury, chest injury, pelvic injuries, spinal injuries, and there is a condition which is called floating knee. It is fracture at the lower third of femur along with the fracture of the upper third of the tibia. It means knee is floating, means hardly any stability. Don't forget fracture neck of the femur, which can easily be missed. Investigation, most of the time, it is a plain X-ray epilateral view of the femur, including hip and the knee. When you are describing the fracture shaft of the femur, don't forget to look for association with the fracture neck of the femur, which is around 10%. CT, it is rarely required, not a routine investigation to be done. Now, how to look for the X-rays and how to describe it. So you have to look for the view of the X-ray and part X-ray, which part, which side. So say for example here, if it is right side, so it is X-ray of the right femur, including hip. So this is the way usually you can find hip and knee as well. Then location of the fracture, upper third, middle third, lower third, you have to tell. You have to describe the displacement. So in fact here, this has been abducted, but you will be describing, because the distal fragment is medial to the proximal fragment, it is described as medial displacement. You have to describe whether comminution or not. So more than two fragments, one fragment, two fragment is usually with the fracture. There is additional fragments, it becomes comminuted fragment, comminution. So it is a comminuted fracture, and neck of the femur you will be looking. So see the example, this is the spiral fracture. Just like remember the spiral staircase, it goes in multiple directions like this. Can you see this? This is a spiral fracture. This is oblique fracture, going like this, going like. And come to the management. There are three types of management that can be asked to you. Whether it is transportation, how will you be transporting the patient from the site of injury, A&E management, and then definitive form the management. So transportation is done usually after application of the Thomas splint. You can transport the patient from the site of injury. What is the management in A&E? You have to immobilize the fracture by traction on a splint, on pillow, whatever you want. The skin traction or sometimes the skeletal traction, whichever is suitable for that particular patient. You have to take care of the pain, so you have to give analgesics to the patient. And IV drip is to be given because blood loss is quite significant, 1 to 1.5 liters in a closed fracture. There are some Hare traction splint available, so this can be applied and patient can be transported as well many times, but usually Before the skin traction or skeletal traction, this is the way you apply it. This is skin traction, you can see it, a temporary method always, and definitive method could be conservative or operative. Conservative nowadays is not done. Usually it was done in the past 4 to 6 weeks with the skin or the skeletal traction, and then femoral cast brace, which used to be called Sarmiento's cast bracing. So you free the knee where the knee can be bent and plaster is still in the whole of the thigh and whole of the leg, and patient can walk. So timing of the surgery, it is after the resuscitation is complete and patient is in optimal condition. There is no other part of the body which is involved. Usually abdomen, chest, brain injury has to be ruled out. So it depends upon the age. The modality of the treatment in children is different from the adults. Children below 2 years and less than 12 kg of weight, you can see in those younger people or younger children, the remodeling has a very high capacity. So shortening is up to 1 to 1.5 centimeter and angulation of 30 degrees are quite acceptable. And many are advising just apply hip spica with or without close reduction. If close reduction is also not needed. Remodeling is will take care of everything. Or you can do the Bryant traction, hip in 90 degree of flexion and knee in slight flexion. You can see this is the Bryant traction or Gallow traction. Age 5 to 11 years. In case of transverse or oblique fracture patterns, we are usually stable. You can use flexible intramedullary nail. In case of unstable, grossly comminuted spiral fracture or very proximal or very distal fractures, you can do submuscular breast plating or sometimes external fixation. This is the hip spica. You can do it in different ways: unilateral, 1.5 spica, and bilateral long leg hip spica cast. The operative treatment in adolescents, usually the flexible Ender's nail, whereby you can spare the epiphysis or epiphyseal growth plate. From the just above the epiphyseal growth plate, you put the nail and it goes bends and fixes the other part of the cortex. Then again, other side you put it and it is abutting in the middle. It is abutting with the cortex, thereby fixing the fracture. Plating can be done in adults. K nail, this is the puncture nail. Full name is puncture nail with the clove leaf appearance. Used to be done some 4 decades ago. Nowadays, it is almost not being done because rotational hold is not good. Interlocking nail is being done nowadays in vogue. Plating, sometimes it is done. For open fractures, it is external. So we come to an conclusion. Intramedullary nail, we are not doing nowadays simple intramedullary or K nail. We are doing interlocking intramedullary nail, and that too with the reduction by close means. So close reduction and internal fixation with interlocking nail. Now this nail could be done with reaming or maybe unreamed. You ream the medullary canal to fix the wider diameter interlocking nail, or with unreamed you have to be happy with the or satisfied with the smaller diameter the interlocking nails. It can be done with the antegrade or retrograde. Antegrade means you are putting the device superiorly from the piriformis fossa in between the greater trochanter and the neck, the femur. Retrograde through the knee joint, it will go in the femur. Plate fixation, there could be DCP, the most common plate, dynamic compression plate. Another can be, many people are doing it, LCDCP, low contact dynamic compression plate. And locking plate has come in a bigger way. In some of the osteoporosis cases, you do locking plates. Remember, gold standard for the treatment of the fracture shaft of the femur is IM interlocking nail or intramedullary interlocking nail. Can be done antegrade or retrograde, and this is the choice of the treatment for most of the femoral fractures in adults. Advantage is it is not fracture site not usually opened. It gives a good rotational hold, so distal fragment cannot rotate, and it also prevents shortening in the case of comminuted fractures. Remember, for the proximal and distal one-third fractures where the medullary canal is very wide, plate may be a choice. Sometimes you can do away with the nail. So not done nowadays, so we won't go in that part. This is the interlocking nail device. You can see interlocking nail has been fixed with the interlocking nail. Interlocking means two screws has to be passed. You can see it, the site where the screws will pass one cortex of the bone through this hole in the device and another cortex like this. You put it, this comes, this is called interlocking. So what are the advantages of the interlocking nail over the plating? First is open reduction is not required in the interlocking nailing. So infection rate at the fracture site is almost nil, negligible. Ulnar rate becomes high because fracture hematoma is preserved, and fracture hematoma contains all the multipotent cells which are going to differentiate in the form of cartilage in the bone. Osteogenesis starts there. Also, the cambium layer of the periosteum is preserved, whereby when you apply the plate, this cambium layer of the periosteum at that particular area is destroyed. And this layer lays down new bone. So bone healing is preserved. Load sharing versus load bearing. Intramedullary nail is a load sharing implant. It shares the load along with the bone, whereas the plate is load bearing. It takes away the load which is there on the weight bearing, and so there is a stress shielding. I mean, stress is not over the bone at all, and that's why peri-implant fractures are less in the intramedullary nail and more in the plates. There is, when you are putting the nail, you are putting it in the medullary canal, so it is a centric fixation. Whereas the plate you are putting over the surface of the bone, it becomes eccentric fixation. And that's why the weight bearing can be allowed in the nail and not with the plate. IM nail can be left in place for almost theoretically indefinite period because a plate is over the bone, it is covering a significant portion of the periosteum which has become dead, and thereby the blood supply to the cortex is impaired, and you have to remove that plate to restore the metabolic activity of that part of the cortex. It has to be removed. In case of delayed union, there is a process called dynamization. So you can do the dynamization in the nail system, but for the plate you have to open the fracture site, remove the plate, redo, and then there is this two operations, and opening the fracture site is always fraught with the dangers. So dynamization is you remove two screws from one part of the bone, either distal fragment or the proximal fragment, and allow the patient to have partial weight bearing. That induces osteogenesis at the fracture site. Remember, when the plate is removed, there are holes left in the cortex and they become a site of the predetermined breaking points. The bone can break there. So there is a post plate removal fractures which are common. You have to protect the bone. What are the complications? Complications are early and late. Early complications could be hypovolemic shock, phytomolism syndrome, compartment syndrome, and injury to the popliteal artery, especially when the fracture is the supracondylar fracture of the femur. Late complications, it is delayed union, non-union, malunion, and there could be knee stiffness when the knee is immobilized for a longer period of time. And some cases can show implant failure. So see the malunion, a gross malunion in the femur, and the treatment will be corrective osteotomy. So this is the corrective osteotomy being performed. You can see it here, and you have to do corrective osteotomy. After corrective osteotomy, nail has been fixed, interlocked, and the eye is now straight. This is a one example of implant failure where there is a implant has been broken. Could be non-union. So see, there could be hypertrophic, oligotrophic, and atrophic form the non-union. Hypertrophic, there is a lot of callus, but they are somewhere else than at the fracture ends. So see, this fracture gap, they are not breaching. They are abundantly present all around. So fracture gap is present, it is a non-union. Oligotrophic, there is a callus, you can see it, but still not, fracture gap is not breached. Atrophic, absolutely no callus. So remember, this is a case of fracture shaft femur. Again, stressing, this is a common injury, commonly asked in the examination. So you must know the anatomic peculiarities, you must know the clinical features, must know how to examine on inspection, palpation, and you must know how to measure it, to demonstrate to the externals and internals, and then how to read an X-ray, and then how to manage it at 3 levels during transport, A&E management, and definitive form the management, and lastly, what are the complications that you can face when you are dealing with the fracture shaft of the femur.